Asherman, the nightmare for gynecologists. Every Asherman surgery is a new adventure. Every Asherman surgery is a thrilling experience. Hesitation, expectations, worry, and fears. Entering the mysterious temple, the uterine cavity, with a lot of fears. What will you face inside? Frustrations at the start, just only a pinhole at the level of the internal os. So this red line is the clue. This small blood line tells a direction. So going by the tip of the scissor and gently, very gently, try to open up and widen this pinhole. So how I use this red line as a clue? Just by increase and decrease the fluid pressure, this will allow this thread of blood to go inside and tell you, come and follow me. Very gentle cut by the tip of the scissor. Don't open the scissor jaws till the end. Cut and touch, cut and touch, trying to find a clue to the proper direction. The mistake frequently happen in Asherman surgery is going into a false track and creating another Asherman. The situation now looks like a septum. It's not a uterine septum, it's a central adhesions and creation of two directions on the sides of these adhesions and then cut in the center. A gentle push by the tip of the hysteroscope to enter the space created. This pinkish color of tissues gives an optimistic view that this is the proper direction of the uterine cavity. So each step leads to another successful step. If you find yourself going into only white tissues, you are into a false track. But these pinkish islands and these threads of endometrial tissues gives the clue that this is the proper direction. So hysteroscopy is a tissue-based structure surgery. Your eyes should be very familiar with the change of color of tissues between fibrous, endometrial, myoma, adhesions, that this help you to go into the proper direction. Let's go further inside. I could hear the voice of every one of you now calling with a loud voice, yes. This is the healthy cornu with a very healthy tubal ostium. So this is the landmark of the upper end of dissection. This is the clue that the dissection started from below, ended into a proper cavity expansion. So once identification of a landmark, then try to imagine. Again, hysteroscopy is imagination. To try to imagine where is this geographical point. So this is one cornea, so I start to move and search for another cornea. Going through a very dense white tissues, I'm almost like a blind man. But taking the tubal ostium, which was identified as a landmark, you can work by imagination. It's purely imagination, trying to reach the other ostium. So either you are successful and reach other cornea, or you are into some other place. Let's go in. Let's go in. Slowly cut the adhesions. There is something pinkish high up. Yes. Elevate, cut, expand, have faith, have confidence, and you reach your goal. Yes, this is the other tubal ostium. This is the most fantastic, happiest moment that a surgeon can feel. When you start working in the dark and then you see the light. Now you can see a very beautiful reconstructed cavity. You can see healthy corneas on both sides surrounded by healthy endometrium, which hopefully will regenerate and help to cover this cavity. And throughout the cavity, there is a lot of white areas, which were the site of the adhesion. So this is one tubal ostium, cutting laterally to expand more. I usually do over expansion to compensate for the possible re-adhesion back again. So this is the final view, and this video is a real-time video. You shared with me the moments of fear, worry, hesitation, frustration, and victory. At the end of surgery, we put a Foley's balloon, and insertion of the balloon is done under vision for two purposes. Number one, to check the proper placement and position of the balloon, that is not coiled inside the cavity, it's not in the lower uterine segment. So checking the position. And as you see here, the balloon is coiled inside, so inflation will not be easy. So now you can pull out on the Foley's catheter to look at this. It looks like a snake coiling inside, and you will enjoy the repositioning and adjustment by just pulling on the, yes, pull out, more, to make sure that the Foley's is properly adjusted. And then second point, inflation is done under vision to estimate the volume of saline needed to inflate the balloon. If you inflate it too much, it will be painful for the patient post-operative, and she will not tolerate. If it's too little, it will slip and fall off. So inflation of the balloon under vision has many values, and it's left for 7 to 10 days. And after removal, after 10 days, we do repeat hysterography again to check the results of surgery. So here you see the cavity and gradual inflation of the balloon. And then pull out slowly to make sure that the balloon is inside the cavity, not inside the cervical canal. You will check. This is the internal os, so happily it's well adjusted. Let's now check the results of surgery. That was the pre-operative hysterography, and after 10 days and removal of the balloon, that's the results. Nothing is impossible. It always seems impossible until someone is able to do it. And then everyone else should have the faith and confidence that he is able to do it. My dear friends, thank you very much.